2016. This is one from US Flu VE network data that was presented at the June 2016 meeting. The red ellipse marks the LAIV4 VE estimate for H1N1 PDM09. Point estimate was minus 21% and was not statistically significant. Also presented at that meeting was this slide from the MedImmune Icicle study. Here we have a point estimate of 50% higher than the minus 21% previously, however, still also not statistically significant as the confidence interval crosses 0 rather. So there was a third estimate from the US DoD, which had a point estimate right in between these of 15%, positive 15%, but similarly to these two was not statistically significant. So I did this to illustrate something that's become a major point of discussion since those data were presented. As we mentioned, the primary concern that led to the recommendation not to use LAIV in the United States centered around H1N1 PDM09 VE during the 13-14 and 15-16 seasons. One of the things that was observed over the course of those presentations and as subsequent papers came out reporting more final data is that higher point estimates of LAIV4 effectiveness against H1N1 PDM09 varied among the US studies. And also, higher point estimates were observed in studies conducted outside the US. For example, Canada, the United Kingdom, Germany, and Finland, which have continued to use LAIV to date. In general, most of those estimates were not statistically significant either, with one exception, but the point estimates were notably higher. This became a topic of discussion because really what we'd like to do is understand the sources of the variability, and those to this date really are not completely understood. A number of possibilities have been discussed, including differences in the use of trivalent as compared to quadrivalent LAIV in different populations, small sample size and imprecision of estimates that accompanies small sample size, and that is very common when we look at individual studies on their own, especially when we attempt to stratify by different types or subtypes of virus or age groups or vaccine types. And finally, difference in the prevalence of prior vaccination among children in different countries and populations. How exposed to vaccine are these children previously when they come into study? To not solve all these questions, but to hopefully begin to describe them a little better, we undertook within the division 2 analyses, which I'm going to describe next. One is a combined individual patient-level analysis of US studies, abbreviated US IPD for our purposes. This included 5 studies with 3 seasons of use of LAIV4, 2013-14 through 2015-16. The hope here was to have greater power for age group specific analysis and more precise estimates through pooling of data across multiple studies. Additionally, it was hoped that there'd be an opportunity for evaluation of the effect of prior vaccination. The systematic review and meta-analysis, or SRMA, included US and non-US studies from the 2010-11 season forward. Hopes here were for evaluation of quality of individual studies in terms of risk of bias and problems related to small sample size, and also summary VE results and hopefully exploration and at least a description of heterogeneity, if not an explanation for it. So I'll start with combined US data analysis. This was work that was done by Jessie Chung in our division with Brendan Flannery, and she presented this to the ACIP Influenza work group in November. So this slide summarizes the included studies. There are a total of 5. The largest of them is the Flu VE network study with almost 7,000 observations at the bottom of the list. The other 4 include the Icicle study from MedImmune, the Influenza Incident Surveillance Project, also from CDC, the Louisiana State University Health Sciences Center study, and also data from the US Air Force School of Aerospace Medicine Dependence Database. All of these you can see in the N column contributed a pretty substantial amount of data in terms of numbers. However, we do have probably the most from Flu VE network, which sort of drives the findings along with Icicle and LSU. The methodologies in the studies differed somewhat, but overall study inclusion criteria and case definitions, as you can see in the middle column, were relatively consistent. This is the first results slide. These data are actually for inactivated influenza vaccine. On the bottom, we have the age group 2 through 17 as a whole, and then the 3 subgroups 2 through 4, 5 through 8, 9 through 17. These are here stratified separately by influenza type and subtype. All flu AB for all 3 seasons on the far left, then H1N1 PDM09 for 13-14 and 15-16, just 2 seasons there. AH3N2 for 14-15. That was the only H3N2 predominant season in this 3-season range. And finally, influenza B for all 3 seasons pooled. We have, you can see here, a statistically significant VE in the upper 40 to 50% range for all flu. For AH1N1 PDM09, slightly better in the 60% range and statistically significant across all age groups. I'm going to skip to B for a second. Also significant VE for influenza B pooled across the seasons. For H3N2, we have that one drifted season, 2014-15, less consistent results, no statistically significant effectiveness for 5 through 8 or 9 through 17. There is statistically significant effectiveness for 2 through 4 years, which perhaps drives the significant effectiveness for the 2 through 17-year-olds at 29%. This slide is formatted in exactly the same manner, and it contains exactly the same 3 seasons in each box, but these are the results for LAIV4. We see for any flu across all seasons, statistically significant effectiveness, lower than IIV, but significant with the exception of 2 to 4-year-olds where it's not statistically significant. H1N1 PDM09 for those 2 predominant seasons, no effectiveness estimate is significant except among the 9 through 17-year-olds. H3N2, none of this whole age range or age subgroup estimates are statistically significant. And finally, for influenza B, in a bit of contrast, a statistically significant effectiveness in the 66 to 71% range across the age range. I'd mentioned that there was hope that we would be able to examine effect of prior vaccination, and this is a slide that attempts to describe that. These are results specifically for H1N1 PDM09. In each box, there's a comparison between the VE for IIV versus LAIV. Unvaccinated is the reference. And this is subdivided by, on the left, prior season unvaccinated, prior season receipt of IIV in the middle, and then prior season of LAIV on the right. You can see here that no matter how this is stratified in terms of prior vaccination or not and what was received in the prior season, there is a noticeable difference in the point estimates of VE, which indicates to us that at least within this data set, we don't have an explanation in terms of prior vaccination for the difference in VE between LAIV and IIV. It's possible with greater numbers we might be able to see something, but we're not seeing it here. The last 2 slides of results from this study are relative effectiveness slides, and because they reproduce relatively in a small format, we thought it would be useful to just draw them out here so it'll be easier to find what you need to look for on the next slides. They all use this same scaffold, which is an odds ratio, not VE, odds ratio. We're comparing LAIV to IIV, so a lower number if the estimate and point, there we go. If the point estimate and the confidence interval fall on the left side of 1, that favors LAIV. Those on the right side of 1 favor IIV. Precision of estimates is based on the width of the confidence interval, the bat wings around the point estimate box. And if the confidence intervals overlap 1, which is null effect, they're not considered statistically significant. So with that, here are those results. The first slide here is any flu, A or B, for all 3 seasons. There's statistically significant advantage to IIV for 2 through 4 and 5 through 8-year-olds, as well as 2 through 17, not for the 9 through 17-year-olds. For AH1 PDM09, the point estimates and confidence intervals for all age categories and subcategories fall to the right, favoring IIV. For AH3N2, for the 2014-15 season, significant favoring of IIV for 2 through 4, not for 5 through 8 or 9 through 17. And for influenza B, for this example, all of the point estimates fall on the side favoring LAIV. However, the confidence intervals all overlap 1 and therefore would not be considered statistically significant. To close out this section, just a few words on limitations. One is that the power to detect differences related to prior vaccination was somewhat limited by the sample in the study, in that prior vaccination status was only available for 1 year for some of the studies that were included, and this makes things difficult as previous vaccination status could have been the first dose relative to full vaccination status, which for some children in the 6-month through 8-year age range requires 2 doses. Additionally, all LIIV here is quadrivalent because these are data from 13-14 in the US forward, but both trivalent and quadrivalent inactivated vaccines are represented. A brief, don't have time to name them all, but brief thank you to all of the investigators who were really helpful in contributing data to this work. Next, the systematic review and meta-analysis. I want to give a very hearty thank you to my teammates who spent a really incredible amount of time reviewing papers and slides and plots for this, and it was an endeavor. So we conducted a structured literature search with the aid of CDC librarian Joanna Italiano, who I neglected to mention on the last slide, to whom we're also thankful, of Medline, Embase, CINAHL, Scopus, clinicaltrials.gov, and the Cochrane Register of Controlled Trials for things indexed between January 1st, 2011 and October 31st, 2017. We sought English language publications that compiled data from the 2010-11 through 2016-17 seasons. So these are post-pandemic vaccines. We wanted to not include, the reason for this selection, monovalent vaccines, since valence and interference was one of the issues that had been raised at various times. Key terms are summarized in the next bullet. Reference lists of all the retrieved publications were reviewed to further identify additional published studies that we might have missed in the initial search. Titles and abstracts, and then later articles for those not either discarded or included definitively, were screened by a minimum of 2 reviewers. And articles for review of quality and data abstraction were also reviewed by a minimum of 2 reviewers. Study designs we sought to include were randomized controlled trials and observational studies of test-negative case control and cohort designs. The study population of interest was children 2 through 17 years of age. We did include estimates that included ages slightly outside this range, for example, in one example, 2 through 19-year-olds. However, studies that were mixed populations, predominantly of adults, in which it was not possible to separate out the pediatric estimates, we did not include. The intervention was at least 1 dose of LIIV. Comparators that we were interested in were unvaccinated groups, placebo, non-influenza vaccine, or intramuscular inactivated flu vaccines. Outcomes included laboratory-confirmed flu outcomes. We specified that these needed to be confirmed by PCR and/or culture, and these included things such as medically attended outpatient influenza infections or influenza-associated hospitalizations. Study quality assessment was done with a couple of different tools for randomized studies, the Cochrane Risk of Bias tool. For observational studies, the Robbins I, or Risk of Bias in Non-Randomized Studies of Interventions, which is another Cochrane collaboration tool. We also assessed risk of sparse data bias using concepts adapted from several papers by Greenland et al., which attempt to get at biases that can be adduced when you have a lot of analysis and not many cases in your data set. So, first results slide, literature search results. I won't go through the whole thing, but we started out with a total of 1,136 citations, and in the end had 18 which were suitable for inclusion. To go over the characteristics of these 18 briefly, there were 15 test-negative case control studies, including 9 from the US, 3 from the UK, 2 from Canada, and 1 from Germany. We had 1 prospective cohort study from the US, 2 cluster randomized trials from Canada, and no individually randomized trials. There was a 19th paper, a retrospective cohort study from Finland, which did not meet the testing modality criteria for inclusion. However, because it's an important paper in a number of ways, it was included in a sensitivity analysis to see how it affected our pooled H1N1 PDM09 estimate. From here on in, because we only have 2 cluster randomized trials, because those data, because of their methodological differences, can't be combined readily with the observational studies, and because there are actually some differences between the 2 of them, I'm going to focus on the 16 observational studies. The Robbins I, this is a tool for assessing quality risk of bias in non-randomized studies, observational studies, was applied to each of these papers. We had 0 that we assigned low risk, 13 moderate risk, and 3 serious risk, 0 critical risk. I'll get back to the why of that in a minute. For sparse data bias, we actually looked at individual estimates. Most papers reported more than 1 estimate, so we have more than 16 estimate assessments for sparse data bias. For the 45 estimates of LIIV versus unvaccinated that were used to assess VE for ages 2 through 17 years, 16 were assigned low risk, 2 moderate risk, and 21 serious risk. For 6, we didn't have sufficient data to make a determination. So I wanted to mention something about the why of this because it's kind of interesting, because there's a little bit of a seesaw in this, in that the papers that were assigned serious risk were assigned serious risk basically for the same reason, which was lack of adjustment in the model for a potential confounding variable of interest. When one approaches papers with this tool, one thinks of what would we think are potential confounders that we would want to see adjusted for, or that an explanation is given for why there's no adjustment for it. So in this case, that was the reason. However, on the other side of the coin, the estimates that were assigned serious risk most commonly received this designation because events per variable, or EPV, was less than 10. And this is a way of saying basically that the model adjusted for too many variables relative to the number of influenza cases that occurred in that stratum. So we want to know about confounding and think about it and adjust for it, but sometimes we don't have enough flu cases to be able to do that reliably, but sometimes we do it anyway. And that can lead to some instability of estimates. So the next 8, I apologize, slides are plots. I'm going to go this one slightly slowly because that will help make the rest slightly more quick. These are forest plots. We are dealing again with odds ratios, not VE in the plot. You're going to see in each one a series of estimates. In some of them, it's noted that they are ordered by precision, more precise estimates at the top, going to less precise estimates at the bottom. In each, you will see a light blue diamond at the bottom, which represents the pooled OR and confidence interval. And to make things slightly easier to read, I have put the translated OR into VE in a little blue box off to the left in each slide, hopefully a little bit more legibly. So for this one, this is odds of influenza A or B, so any flu virus infection among children receiving LAIV compared to unvaccinated, ordered by precision. One thing I want to point out here is that you can see as you go down the graph, this occurred in a lot of the plots we looked at, and we didn't expect to see it, is that there seems to be a tendency for lower precision estimates, the less precise estimates, to report lower OR, which would mean higher VE. We don't know why that is, it's just something we've observed. The pooled OR is represented at the bottom of the plot and represents a pooled VE for these 15 studies of 45% with a 95% confidence interval of 32 to 56%, which would be statistically significant. This is a similar kind of plot. Again, it's LAIV versus unvaccinated, but this is for H1N1 PDM09. You can see a similar trend towards less precise estimates reporting lower ORs and higher VE. In this case, we have a pooled VE of 25% with a confidence interval of 6 to 40. This is also statistically significant. However, it is lower than the 45% that was reported for all flu A and B. This is, I think I hit the wrong button. Let's see. There we go. Okay. So odds of influenza AH1N1 PDM09 again. This time these are stratified by location very broadly, US versus non-US. We have 6 US studies, 4 non-US studies. These are just the same estimates that you saw on the last slide. We've just stratified them. So we have 2 separate pooled ORs. For the US study, VE is 17% with a CI of -6 to 35, not statistically significant. For the non-US studies, 48%, 15 to 68, and statistically significant. A comment regarding the estimates for the non-US studies is 3 out of 4 of them. You can see that they're fairly imprecise estimates. And those were also papers that were downgraded slightly in terms of study quality for terms of either not adjusting or adjusting for too much. In this case, I believe it's not adjusting. H1N1 PDM09, again, versus unvaccinated by LAIV formulation, quadrivalent versus trivalent. In fairness, I should mention that because of where we set our search horizons, starting with 10-11 season, that effectively removes a lot of trivalent estimates that have historically been reported, but we did want to start with a period of time when there was no monovalent vaccine and when H1N1 PDM09 was around. It does, however, make it a little bit difficult to interpret that trivalent estimate because of the lack of precision, and you can see how spread that blue diamond is. Looking at LAIV4, the VE is 24% with a 95% confidence interval of 2 through 41%. So the next 3, actually this one is the sensitivity analysis first. Again, we're still on H1N1 PDM09. I mentioned that there was an additional study. This is Neunek et al. This is a study from Finland. It's a little different from some of the others in that it's only 2-year-olds, so it's a relatively narrow age band. It does report an estimate for influenza A, not H1N1 PDM09 specifically, but because of what we know about what was circulating at that season, we're presuming it to be mostly H1N1 PDM09. This paper, again, didn't meet the testing criteria that we set for inclusion. However, it is an important paper in that we do have national data from it. It was also one of the few statistically significant estimates for LAIV for that season, which was 2015-16. Therefore, we felt it was important to see if including it had any significant effect on our pooled estimate. Again, on the left, this is similar to what you saw before, excluding Neunek, 25%, 6 to 40% for VE. Including it on the right, 31% with a CI of 13 to 46%. So there is a slight change upward towards greater VE, however, it's not substantial. The last 3 plots are relative effectiveness plots, and these are formatted very much the way the sort of cartoon drawing that I showed earlier indicated. Again, we still have odds ratio. We are comparing LAIV relative to IIV. The left side of one favors LAIV, the right side of one favors IIV. If it crosses the middle, it's not considered statistically significant. This is for H1N1 PDM09, LAIV versus IIV. The pooled estimate falls completely, including its confidence intervals, to the right side of 1. The pooled odds of flu H1N1 PDM09, if you got LAIV as compared to IIV, is 2.52, with a 95% confidence interval of approximately 1.6 to 4. This is the same information, except now this is influenza B virus infection. This time, the center of the blue diamond, which is more or less the pooled point estimate of the odds ratio, falls to the left, the side favoring LAIV. However, the tail of that estimate does fall over 1. Therefore, this wouldn't be considered statistically significant. Lastly, H3N2. This one sits squarely on 1.01 and would not be considered statistically significant, so essentially no difference between LAIV and IIV for H3N2. Because we can't show all the plots, this is a table summarizing some of the results you didn't see. We did look at the flu A, flu B, and PDM09 versus no vaccination. Those are the first 2 lines in the table. LAIV versus no vaccination for H3N2, that's the 3rd entry in the table. VE 38%, 13 to 56% for CI. And influenza B 69%, 52 to 79%. And again, these are all for LAIV versus no vaccine. When we look at relative effectiveness estimates, here we're dealing with pooled ORs. We discussed most of these already. We have for H1N1 PDM09, better VE for IIV. For B, some suggestion of better VE, but the point estimate is wide and not, the confidence intervals are wide and the estimate's not statistically significant. So some summary points for these analyses. 1, looking at LAIV versus no vaccine for H1N1 PDM09. There's significant effectiveness for the older kids, the 9 through 17-year-olds in the US IPD. In the systematic review, there's significant effectiveness only in the non-US studies, of which more imprecise estimates with higher risk of bias made up 3/4 of those. No studies included in this analysis are from the 17-18 season, so therefore we have no estimates with effectiveness for LAIV containing A Slovenia. LAIV versus IIV for influenza A H1N1 PDM09, so a relative effectiveness estimate. IIV was better for all age groups in the US IPD. IIV was also better in the SRMA. LAIV versus IIV for flu B, point estimate favors LAIV for both analyses, but not statistically significantly different. LAIV versus IIV for AH3N2, IIV better for 2 through 4 years in the US IPD, the very youngest kids. No significant difference in any other age groups or in the systematic review. Some limitations for both these analyses: the EB lineages are not analyzed separately. Relatively few estimates, there were few, but not many, report lineage-specific BVE. LAIV4, again, is compared against a variety of different products in these cases, all IIVs. In general, we don't know the relative proportions of IIV3 to IIV4, and as we all know, there are many different IIV formulations available, and we actually don't know a lot about how well they work relative to one another. Some general limitations: there's no US VE data available for LAIV4 since 2015-16. And again, the VE for the current LAIV4 formulation containing A. slovenia against H1N1 PDM09 viruses is not known. So before we move on, a little bit to sort of put this work in context in terms of what we know, what's new, and what we still don't know. The putative root cause for the poor efficacy of LAIV against H1N1 PDM09 in 13, 14, and 15, 16, as was mentioned, was postulated to be poor replicative fitness of that virus. LAIV4 now contains a new H1N1 PDM-like virus, A. slovenia, since the 2017-18 season. It has not, we believe, been used a great deal here because while it is approved and I believe was available, with no recommendation, we don't expect to see much use. However, it was used in the UK, Finland, and Canada. Unfortunately, our current season thus far is H3N2 predominant, and therefore we have no H1N1 PDM09 VE estimate. Recent shedding and immunogenicity data that you've seen for the new H1N1 PDM09-like virus is encouraging. However, again, the effectiveness of this formulation against H1N1 PDM09 is not known and is likely to remain unknown until the next H1N1 predominant season, assuming adequate uptake of vaccine. We can't predict when this will occur. A couple of thoughts also about variability in VE estimates. In each of those plots, you saw that they do vary, and we expect that to happen. There's a lot of factors that influence VE: host factors, influenza type and subtype, different seasons. Moreover, it's possible that individual vaccines vary in their VE. There are many vaccines licensed in the US, currently a total of 13 unique products. Estimates of effectiveness of individual products may vary, possibly even within a given category, for example, even among different IIVs. However, in many instances, comparative data for different individual products in a class are not available. There are some exceptions, but in general, this is not something we see. Recommendations for other individual influenza vaccines have not generally been based upon comparative effectiveness data, with the exception of preferential recommendations, but just the decision of recommending or not a vaccine in the past has not generally been recommended on that sort of criterion. So conclusions for this section: since 2013-14, a plausible root cause of the poor effectiveness of LAIV4 against H1N1 PDM09 has been identified. There's encouraging shedding and immunogenicity data that you saw today that the problem might be addressed with a new H1N1 PDM09 virus, A. slovenia. Important caveat is that whether this problem is solved definitively will not be known until there is an effectiveness estimate against H1N1 PDM09. We don't know when this will occur. New LAIV vaccine virus selection processes are to be applied going forward, and we heard a bit of a summary of that from the MedImmune presentation. And from these analyses, combined analyses indicate LAIV4 is effective compared with no vaccination against all flu and flu B among 2 through 17-year-olds. IIV was better in these analyses against H1N1 PDM09. Again, we don't have an estimate for the current formulation, though. No clear difference in performance between LAIV and IIV for H3N2. And finally, decision to recommend or not individual influenza vaccines, generally not based on effectiveness comparisons to other products. So I would like to summarize the work group considerations, although Dr. Bennett, if you think it's better to pause for questions, I can do that too.
Actually, I think you should keep going.
Okay, thank you.
Thank you.
Okay, I'm sorry that was a bit of a whirlwind. Okay, so I'd like to summarize some of the work group discussions. A very quick thank you, because I haven't had opportunity to do it yet, to the CDC staff who contribute immeasurably to the work group presentations on an ongoing basis. So there was a great diversity of sentiment in the work group discussion of this issue. We've heard a lot of data related to LAIV over the last 4 months, really over the last couple of years, but the last 4 months quite a bit. While there is a lot of diversity of opinion, one thing that folks tend to agree about is that influenza is a problem for the pediatric age population. It's an important cause of morbidity and mortality in children. Pediatric deaths, as was mentioned a little earlier today, associated with lab-confirmed flu have been a reportable condition since 2004. We've had deaths ranging annually from a low of 37 to a high of 171 during non-pandemic seasons since 2004-2005. During the pandemic period, which was somewhat longer, 358 deaths. It's also an important cause of hospitalizations among children, as these data from FluView Interactive summarize. These are hospitalizations per 100,000 person years for younger children 0 to 4 years and older 5 through 17 years over the last 4 seasons, exclusive of the current season, 2017-18. Some discussion of benefits versus harms. It's generally agreed that the benefit of the current formulation of LAIV against H1N1 PDM09-like viruses is currently not known. We have no effectiveness estimate yet, and we don't know in practical terms when this exactly will occur. Data suggests good effectiveness of LAIV against influenza B viruses. Data also suggests that LAIV4 is comparable to IIV against H3N2. No new safety concerns, intrinsic safety concerns, were raised for LAIV at the time that the recommendation for its use was removed in June 2016. However, it's recognized that there is potential for harm if the new formulation of LAIV4 is recommended and used and is not effective. Thoughts about how the target population views the balance of benefits and risk. This is a little bit difficult to get at in a quantitative manner. We did want to share that there have been some communications, including at least one, I think, that was shared with the ACIP, the meeting before last in June, in terms of published and unpublished letters, which have expressed concern that lack of a recommendation for LAIV may be detrimental in some settings, for example, school-based clinics. Another point of discussion was that maintaining consumer confidence in influenza vaccines is important in the setting of low VE estimates overall. Risk of recommending LAIV without effectiveness data of the current formulation against H1N1. On the one hand, a plausible root cause of reduced effectiveness against H1N1 PDM09 was identified. This gets to the replicative fitness of the H1N1 contained in the vaccine. However, some in the discussion expressed the view that other factors, even if they weren't the root cause, may have contributed, for example, interference due to the addition of the fourth virus into the vaccine. There were also varying viewpoints regarding the promise of the shedding and immunogenicity data that were presented. Some viewed it as encouraging. Others expressed concern about the size of the study and problems with using immunogenicity and shedding to gauge effectiveness of LAIV. It was a concern expressed that if the issue is not resolved, we'll potentially have more influenza cases. Also expressed was an understanding that influenza VE varies by season for all vaccines, and that initial licensure of some newer vaccines, particularly some more recent quadrivalent vaccines, or vaccines that were already licensed but had licensure expanded to different age groups, in some cases, those changes have been based solely on immunogenicity data. So some make the argument that the risk in that respect could be viewed as similar to introduction of a new influenza vaccine product. Risk that if LAIV is not recommended in the US during 2018-19 or some future season, it may not return to market. None of us know what's going to happen, but in view of the fact that we have ideally a situation where we want effectiveness data, but we cannot easily predict when it's going to be feasible to obtain that, and in view of the fact that it's difficult to do a trial for a vaccine that doesn't have a recommendation, this is something that comes to mind. There was not any expression that that should be something that drives a decision. However, several ideas brought up around this topic was that LAIV does remain a licensed product by FDA in the United States. Another thing that was brought to light through these discussions was the challenge of holding all manufacturers to the same standards for effectiveness of influenza vaccines. For example, now we've examined the effectiveness of LAIV specifically. It's a unique product. It's the only one in its class that's licensed in the US. Its effectiveness has been examined each season for the last several seasons. For most other individual influenza vaccines, recommendation, again, I'm not speaking of preferential recommendations, just recommendations, is not based on annual assessment of a product-specific VE. Has influenza vaccine coverage been impacted by not recommending LAIV? This was something that was expressed as a concern when the initial recommendation was made. In October 2017, the last ACIP meeting, Dr. Carla Black of ISD presented the 2016-17 pediatric coverage summary data, which indicated that compared with 2015-16, coverage remains stable. We believe that local variation is likely, and we have heard reports of reduced coverage in some areas with strong school-based programs that relied on LAIV. We have also heard anecdotal reports from other areas where they said they didn't have any decrement that they noticed in terms of coverage. Another point to bring up, though, is that while national coverage didn't decrease, it also didn't increase and is currently still below goal for coverage for the pediatric age group, and specifically was 2% lower in the 5 through 12-year-old age group, which is a small difference, but in this case was a statistically significant one. This was the slide that Dr. Black presented in October, and it is the 2016-17 coverage for children from NIS flu. The last column shows the difference with the previous 2015-16 season. There is a small but statistically significant decrease among the 5 through 12-year-olds and a small but statistically significant increase among the 13 through 17-year-olds, both on the order of about 2%. So nationally, relatively stable. It is more difficult to get at regional or very local differences in coverage. So to summarize, some of these aspects around the policy question: should LAIV be recommended for the 2018-19 season? Problem: influenza is an important source of morbidity and mortality among children. Benefits and harms: benefit of LAIV for H3N2 seems comparable to IIV. Data suggests good effectiveness for influenza B compared with no vaccine. Limited immunogenicity and shedding data suggests the new H1N1 PDM09 and LAIV4 may promote improved effectiveness. However, this is not yet known. No intrinsic vaccine safety concerns were revealed at the time LAIV vaccine was not recommended by ACIP in June 2016. There is recognition of the potential for harm, however, if the vaccine is used and is not effective. Values: several papers in unpublished letters and published letters have indicated support for the availability of a non-injectable formulation of influenza vaccine. Acceptability: there were varying levels of accepting risk of vaccine not being as effective against H1N1 if it's used, as well as the potential consequence of detriment to vaccine confidence. Implementation: while national coverage data appears not to have been impacted by lack of an LAIV recommendation, LAIV is an important option for school-based clinics and may contribute to efforts to increase vaccination coverage. In summary, there was not complete agreement on the work group. Most felt that the issue should be discussed at ACIP, so we're here today. The discussion around whether or not to vote, opinions were somewhat more diverse about that particular aspect. And it was also raised that a recommendation would need to acknowledge the current lack of effectiveness data for the current LAIV4 against H1N1 PDM09-like viruses. And that is the end of the data.
Thank you, Dr. Groskopf, for that true tour de force. That was really, really, really impressive. I can't believe how much information you got through and how clear it was. Thank you very much. It's really excellent. I think we should take some discussion now, and then we'll move to the proposed recommendation. Questions, discussion? Dr. Romero.
You did a wonderful job on all of this and discussing the acceptability and risks of recommendation. I also bring to the committee the fact that although we are mandated to look at immunization here in this country, the recommendations issued by the ACIP are viewed very seriously around the world, and they have impact around the world. There was a recent publication in the March 1 issue of CID by Sanchez, I think, from Maryland, who commented about the possibility of the impact of a vote by the ACIP on the availability of LAIV outside of the United States, where many countries, or some countries, excuse me, use it as a primary vaccine. So I add that to the list.
Thank you. Other questions or comments? Yes, Dr. Hunter.
So if I'm a clinician with a patient in front of me during a flu season, it seems to me that the guidance I need about whether or not to give LAIV is that if the flu season currently is predominantly H1N1, I may consider the IIV over the LIV, and if it's currently the main concern for that patient in front of me is H3N2 or B, then it doesn't matter which one I give. Would that be a correct clinical judgment, individual clinical judgment type of guidance?
She wants me to say something. So I think the issue is that optimally, your patients will be vaccinated before the flu season starts. And therefore, you won't have the luxury of making a clinical decision based on what's circulating, nor can we predict, honestly, at any point in the season what's going to circulate next. In addition, as I am sure we're going to hear soon from AAP perhaps, clinicians have to make decisions about what vaccines to buy long before the patient is in the office. And so if you didn't purchase that vaccine, it wouldn't be there as an option. And I think most clinicians generally only stock one flavor of vaccine and might not sort of give themselves multiple vaccines as a toolkit. So that may not actually be a fair question.
Yes, Dr. Fry.
I have a question to the pediatricians in this group. So if you are a pediatrician and you were given this guidance of, let me just read this out loud. LAIV is recommended, however, providers should be aware that the effectiveness is unknown. How do you interpret that data, and does that make you less likely to use LAIV, or, I mean...
Actually, maybe we should put up the proposed recommendation, because that's going to be background information, not the proposed recommendation.
Oh, okay, sorry.
Do you have the background language that you created as well?
So just to be clear to everyone, there's a distinction between making a recommendation that LAIV be available for use in the U.S. versus the background statement that we would want to have go along with that. So do you want to put back on the recommendation for a moment? So the vote is whether or not LAIV4 is recommended as an option for influenza vaccination for persons for whom it is otherwise appropriate. But the background information, you can go to the next slide, right, is this. So does that help, Dr. Fry?
So somebody had mentioned about pediatricians. So it is true, many of the pediatricians have already put their orders in, and so they haven't put in an order for LIV. But one of the other things that I think is very relevant, and I think this is true, but Nancy may be able to help with this, is that the VFC has not purchased any LAIV, which means that if we reinstate LAIV, that there's a portion of the population that would be denied access to the vaccine, the VFC population. And so, you know, that's just, again, one of the potential harms that could occur. So I think we have to understand that that would create a disparity.
Yeah, we certainly wish we could have had this discussion earlier, but Dr. Messonnier, do you want to?
Sure. Let me just respond to that. So, you know, it's always complicated when you all make your recommendations compared to the contracting process. It is true that we value entirely the provider community that is going to have to implement these recommendations, and I think we all value making things as simple as possible for the provider community. But let me just walk you through sort of the iterations of what might happen if ACIP makes a recommendation today. It is true that we have already completed our VFC procurement process for this year. That means that the VFC contracts are complete. It is possible, and we are considering if there is enough of a justification to reconsider whether there be a possibility of some additional contracting for this year. That is not our typical approach. There may be extenuating circumstances, and so we will consider that. But if we don't have a VFC contract, providers will have a choice And so for this season, upcoming, providers might choose to harmonize their VFC and non-VFC populations and therefore not to purchase LAIV and to have just IIV. Providers also might choose to offer LAIV as an option for some of their patients and not for others. By a year from now, if this is, re-recommended, that situation would be, resolved. I would also say that many providers also have already completed their purchasing from their private sector for next year. And so we're very unclear what the uptake of this vaccine would be if the recommendation was today. But there is the potential for a gap in the next year between private and public purchase vaccine.
Dr. Lee.
So I'm really struggling with this decision. Partly I'm trying to put this in the broader context of our decision-making as a body, and whether or not we are asking or holding this particular vaccine to a higher standard than any of the others. Because I'll bet if we look closely at any individual vaccine, we'll see season-to-season variability. And if we were to try and chase that down, we could go in a circle and make compromise potentially the supply, just because I think that we're never going to have perfect data, and I just know that there's going to be some variability from season to season. So with that in mind, I guess I'm just asking out loud whether or not we should be holding this vaccine to a different standard. I acknowledge and I'm worried about the potential harm, and particularly if we're worried about pediatric deaths. That does weigh heavily on me. On the other hand, akin to a prior decision-making, this is just saying, do we want to make it an option? It doesn't go as far as stating whether or not we should have a preference, which I might have a preference about what to recommend, but I think I'm struggling with the fact that this is not a preferential statement. It's just making it an option, and whether or not there is a second step that occurs post that option.
Thank you. Dr. Moore?
Thank you. I'd just like to add also from the perspective of someone who runs the VFC program for one of the states, we would consider this in the context of vaccine choice. And so because it is equivalent to, this recommendation is talking about making it equivalent to a lot of other options of brands, while we strive in the VFC program to provide participating providers with as many options as possible, it's not always possible to provide every option for every product. And so we wouldn't consider this the fact that it might not be readily available in the VFC program this year, we wouldn't consider a severe disparity in access, because every child will have access to influenza vaccines. It's just a matter of which brands are available at the time. And that's always a difference. And in fact, some states just provide their clinicians with vaccine, and they don't even know which brand they're going to get. So the clinicians in the VFC program get the first available product regardless of brand. So there's a lot of different ways states handle this, and there would never be considered a disparity whether or not they had access to LAIV, because they'll have access to other options.
Thank you. Yes, Dr. Bernstein.
So like Dr. Lee, I'm struggling with this, but I have to say that there are a number of concerns that I have. I mean, first, I don't feel that there's a real sense of urgency to reinstate LAIV4, since we do have an alternative IIV. And I feel also that the shedding is not nearly as indicative of protection like vaccine effectiveness as we've heard before. I don't think if flu vaccine coverage rates had gone down without the availability of LAIV4, I would feel a little bit more strongly that we actually need to reintroduce it. But actually, the rates have really not been notably impacted by having only injectable products available. And in my mind, I'm a little concerned about whether it would be interpreted that we're compromising our interpretation of the science by accepting shedding data that compares favorably to pre-pandemic studies as opposed to actually having ongoing vaccine effectiveness data. And although, as Dr. Lee mentioned, are we holding it to a higher standard? In some sense, I feel that we might be, but on the flip side, we can't ignore the fact that we know that the vaccine effectiveness of LAIV4 against H1N1 for those 2 seasons was not good. And that's something that I think we need to keep in mind. I'd also emphasize the fact that if we reinstate LAIV4 for 2018, 2019, I think the messaging that would surround such a decision being made without using the gold standard of vaccine effectiveness is likely to be very difficult for both the public as well as providers to understand why we had this tour de force that Dr. Grosskopf did such a beautiful job in sharing with us. And in addition, I think the last thing, the part that really worries me the most, is the fact that if we reinstate LAIV4 without knowing its vaccine effectiveness during an H1N1 season, and then we have an H1N1 season and it results in increased morbidity and mortality associated with that during that H1N1 season, that is likely to undermine administration of flu vaccine for the public, potentially lowering all coverage rates and negatively impacting the country's overall flu vaccine program. So I have real mixed emotions about this because I think we want to protect as many people as we can, and as a pediatrician, especially children.
Thank you. Ms. Pellegrini, and then Dr. Belongia.
So in contrast to Dr. Bernstein, I have very few mixed emotions about this one. We have other cases where multiple vaccines are on the market, and we know one is more effective than another. Witness zoster right now, right? Based on the evidence, we know one is much better than the other, but we didn't take the other one off the market. I think the evidence is pretty clear that this vaccine is better than not being vaccinated. And there are kids who will not be vaccinated without this option. So let's put it out there as an option. Let's give clinicians and parents the chance to talk it over and figure out what they want to give their kids.
Thank you. Dr. Belongia.
Thank you. I want to support what Cindy just said, and I'm also in favor. This is not an easy decision. And we're always challenged to make difficult decisions with incomplete data. And this is a prime example of that. But I do think that given what we know, that this is a reasonable approach to take. And we always have to make the decision based on the best science we have available at the time. And we have more science available to us now than we did a year ago or 2 years ago when this initially sort of came up. I would also point out that we wouldn't know any of this if it wasn't for the Flu VE network that's only been in existence for about the past 14 years, in our 14th year of doing it. And so, because prior to that, it was all based on immunogenicity and obviously pre-licensure efficacy studies for the most part. So that's a credit to CDC and a value to the American public. This network is able to find this sort of thing. But I do think that sort of in response to having found that the manufacturer has done a good faith effort to try and understand the root causes of what likely is going on. And if we consider that, strain changes are made all the time based on immunogenicity, we know this vaccine is a little different insofar as you can't just rely on immunogenicity because it's a live vaccine. But I think if you look at the overall body of evidence based on their in vitro replication studies in epithelial cells, their challenge studies with wild-type viruses in ferrets, in addition to the pediatric shedding and immunogenicity study, which I completely agree does not directly transfer to clinical effectiveness, and we won't know until we get an H1N1 season. But if we look at the whole body of that evidence, I think they've made a reasonable case, certainly as much as we would have expected for any other vaccine, short of running an actual clinical efficacy trial, to be able to say, look, it looks like they found the source of the problem, and it's reasonable to at least allow that to go forward and then collect the data. but it looks like there's a reasonable possibility that in fact, the Slovenia strain will provide comparable protection to inactivated vaccines. The other thing I would point out is that, as you mentioned, the overall VE in the pooled analysis for LAIV was 45% against all flu strains, and the pooled VE for H1N1 was 25%, which is the same as what we're seeing right now for inactivated vaccines against H3N2 this season, again, in all ages. So it gets very tricky when you start looking at individual seasons, individual subtypes, individual age groups, yeah, in different vaccine products. And so I think given that the changes they made, the evidence they've presented, I think, and the language that we see right there, I think that's telling practitioners the best science that we have at this time, recognizing that we don't know for sure.
Thank you, Dr. Belanger. Could I ask Dr. Sun to make a comment on the plans for going forward?
Yes, hi, this is Wellington Sun from FDA, and we do have a prepared statement, actually, as part of this discussion. So the FDA licensed FluMist in 2003, and to date, the only intranasal influenza vaccine approved in the U.S. for prevention of influenza due to influenza A and B viruses. So the approval was based on randomized controlled clinical trials demonstrating its safety and effectiveness. The FDA acknowledges that recent observational studies raised concerns about decreased effectiveness of FluMist quadrivalent, primarily during season in which H1N1 pandemic 2009 strain predominated in the U.S. So during that time, FluMist has continued to show expected effectiveness against H3N2 and B strains based on similarly designed observational studies both in the U.S. and abroad. Predicting which strains will predominate in future influenza seasons has been challenging historically. Consequently, the licensure of influenza vaccines has been based on prevention of all influenza caused by circulating A and B strains, as demonstrated by our pivotal prospective randomized controlled clinical trials. The variability of influenza effectiveness from year to year is well recognized and unpredictable. Previously, FluMist has demonstrated increased effectiveness in young children in some years. So given that FluMist quadrivalent is a live attenuated influenza vaccine, FDA has requested MedImmune to conduct prospective observational post-marketing studies at the time of approval back in 2012, the ISICO study, to assess the vaccine effectiveness in 2 to 17-year-olds in the U.S. over the course of 4 years. The study was designed to assess vaccine effectiveness over four influenza seasons. And although the 4th year of the study could not be completed due to insufficient use, the first 3 years' data have corroborated the other observational studies results and meta-analysis supporting continued overall vaccine effectiveness against influenza. And FDA maintains that based on the totality of the pre- and post-licensure clinical and manufacturing data, the benefit of FluMist quadrivalent continue to outweigh the potential risks. And FDA has worked closely with MedImmune to conduct comprehensive root cause analysis of the lower than expected effectiveness against the H1N1 2009 strain, including new methods and assays, for example, measuring viral replicator fitness and other unique characteristics of the H1 pandemic strain. And FDA will review and evaluate these new manufacturing and characterization data for each new strain that is incorporated into future vaccines. And these additions and improvements in the manufacturing and assays to better characterize the H1N1 component will be submitted as supplements to the product license and incorporated in future manufacture of the vaccine. FDA will continue to collaborate with CDC, ACIP to ensure continued safety, effectiveness, and optimal use of this in all licensed influenza vaccines. So that's our position at this point.
Thank you very much. I'd like to ask if we could make a motion and then continue our discussion just so that we're moving forward. There are a number of people I have listed here who I know want to make a comment, but I think we just make the motion and then we'll go to those people. So Dr. Walter?
Yeah, I'd like to make a motion that for the 2018-19 season, LAIV is recommended as an option for influenza vaccination for persons for whom it is otherwise appropriate.
Second.
Wait, Dr. Okay, Dr. Newsel, you were next on the list.
Yes, thank you. I think a lot has already been said, so I'll leave my remarks to what I feel are new points. You know, we've all acknowledged the inherent variability of influenza, and Ed, I agree with you completely that this emphasizes the value and importance of our surveillance systems. I would also say that we know there are limitations to those systems, and I don't think they were ever designed to direct policy on a year-to-year basis in certain subgroups for some of the reasons that we've heard, predominantly related to power. I would say there's another limitation that we haven't really considered, and that is that the main outcome we're looking at is all severity influenza, and generally it's mild disease. So I think we have to be a little bit careful to extrapolate that to morbidity and mortality and assume a vaccine might not actually be effective against more severe disease. So again, it's the information we have, but we need to acknowledge that limitation. We're not talking about transmission. We're not talking about other outcomes. We're simply talking about all severity influenza. I think my second point is we want to be very careful with the use of the word harm. Influenza vaccines have been studied extensively. They have a very strong safety record. If an inactivated vaccine is better in 1 year compared to another product in a certain age group for a certain strain, or another one is a different year, I don't consider that to be harm. So I would just like us to be more precise with our language and be sure the public understands that these are extremely safe vaccines.
Thank you. Dr. Atmore?
I just want to respond to a couple of things that Dr. Bernstein raised that haven't been addressed yet. And I raised the same question about being able to make this kind of vote for this kind of recommendation a few meetings ago without vaccine effectiveness data. But my thinking has evolved since then, both through the work group discussions and discussions with others. And at least in part, the reason is that some of the data that were presented today, including from the manufacturer, you know, the shedding data really isn't supposed to be a correlate of protection. What it was asking was, is there evidence of interference, or is the H1N1 less replicatively fit, is the way they present it. The way I interpret the data is the lower fitness leads to susceptibility to poor immunogenicity, and you know, the result of other viruses being present in the vaccine, there's interference that takes place, and so it hasn't worked. They've identified that as an issue, and they have developed assays to try and prevent that from happening in the future. And in fact, their shedding study shows that back when H1N1 worked as a component of the trivalent vaccine, they're seeing similar kinds of findings. So that's reassuring. So, you know, because of that, because of some of the meta-analysis and systemic review information that was presented, think that it's reasonable to come back and vote for this kind of recommendation.
Thank you. Dr. Stevens.
So I want to go back to your last sentence on your slide, Lisa, because I'm a little confused about what we're doing with this vote, because you said there would need to be a recommendation about, and it says specifically, a recommendation would need to acknowledge a lack of effectiveness data for current LAIV against H1N1. That's not what we're saying in the statement that was just approved?
No, it's not so much part of the recommendation. With each new recommendation, we summarize the data that goes into that recommendation, usually in two formats, a short format and a long format. And it's important to summarize the data.
Lisa, will you show the language you have after the vote that will appear as part of the guidance?
Yeah, this is what I was asking about. Can you comment on this language, or someone comment on the language that this would go out in addition to the vote?
So this is not, the vote is for whether or not you would consider recommending LAIV for this next season. This language, if the vote is approved, would be incorporated into a statement about the vaccine recommendations, as we always sort of write sort of the rationale of the CDC guidance around the recommendation.
I would just like to clarify for the group. So I was struggling with not whether or not to approve moving forward with LAIV, but the language that I was reading in this handout, and I'm like, I couldn't reconcile the language. So this really helps.
Thank you. Dr. Fry, I had exactly the same response to it, and hope that we would be able to clarify it by having a much more streamlined recommendation with all of the information put into the background material. So we agree. Dr. Kimberlin has been waiting for a while.
Thank you. David Kimberlin, AAP Red Book. The American Academy of Pediatrics will not have a full response on this until the data are considered at our spring meeting, which will occur next month. We have had, in response to hearing that there will be a vote now, I guess, since the motion has been made, at this meeting, a couple of calls, including one late last night, to try to pull together our thoughts on this, at least as they stand right now, with the caveat that we will have further deliberations. At the current time, a number of concerns have been raised among the Academy and the Committee on Infectious Diseases. The meta-analysis that we heard today crosses, well, a decade and a half, crosses too many different formulations, LAIV3 and LAIV4. It's too blended, in other words, to really, for what we're seeing, pull out strong consideration that LAIV4 has the kind of effectiveness that we are hoping that it may have. We just don't see it right now. In addition, comment has been made about flu vaccine uptake not being hurt by lack of LAIV. We have another product, in other words, that has not been shown to have the questions that are surrounding LAIV. And so the feeling among the discussion to date is sort of what's the urgency with that? We have the disparity concerns that Dr. Brady has raised. The number of children assessed in the study that MedImmune presented was 67 children for the group getting the new formulation of LAIV4. That's a very small number, and has been stated does not include effectiveness. The product, this is my own comment here, the product was sort of de-recommended, if that's a word, because of problems with effectiveness. We've not seen that resolved to make another comment about whether it should be used in the future. That was my own aside. In addition, considerations from the Academy are that the shedding does not necessarily correlate with efficacy or effectiveness, as has been mentioned. And there's concerns about messaging as well. Under the benefits and harms, recognizing that harms perhaps is a word, if you could back up 3 slides or 2 slides now. For me personally, the second row, benefits, harms, final bullet, potential for harm if vaccine is ineffective. If we have an H1N1 year and this vaccine has been recommended again for use and it doesn't work because we don't have effectiveness, that's a sobering sentence for me. Thank you.
Thank you. Dr. Lee?
So just a quick comment, and then I wanted to propose an amendment, which is, and hopefully I did this right, not yet. So did I do the right order? Okay. So the comment just being that I think we're struggling because for the first sort of times now, we're starting to think about effectiveness as opposed to effectiveness. It used to be we were always compared to placebo. So to me, this question is really about effectiveness. Is it better than nothing? And the answer is yes, it's better than nothing. You know, I think Dr. Bernstein raises good questions about whether or not it could augment the overall population protection if we really are augmenting the number of doses given to the entire population. But that said, for now, I would consider this, is it effective compared to placebo? But I wanted to add the amendment about preferential vote. And I wonder if this group would want to consider whether or not we want to go further, in addition to this vote, amending it by stating that there is a preference for IIV over LAIV4 in the coming season as a consideration.
I actually don't think that would be an amendment to this. I think that should be a separate motion. So,
Can I?
Dr. Weber's been waiting, I think.
Just a quick statement, really, more for the, as they're writing the statement here. In the past, there'd been the statement about LAIV, and I'm quoting directly from the CDC recommendations. Persons who care for severely immunocompromised persons who require a protective environment in the hospital should not receive LAIV and should avoid contact with persons for 7 days after receipt, given the theoretic risk for transmission of live attenuated vaccine. So first question is, will that also be included in the statement this time? And if so, based on the data that we saw that children were still excreting at 7 days, will there be a recommendation that children who've received LAIV be prohibited, in addition to the healthcare personnel, for longer than 7 days because they could still be excreting? So are you going to pick a longer time, like 10 days or some other time? Thank you.
The shedding data for adults tends to be much shorter. Shedding is most pronounced among children with a first dose, and in some previous studies has gone on for longer than a week. So I don't believe that's actually new, but that's certainly something that we can discuss within work group.
Yes, Dr. Brady.
So right now, you have up there LAIV is recommended as an option. So actually, currently, it is an option because it's FDA licensed and pardon me?
It's not an option according to our
No,
recommendations.
I'm going to get to that. So what I was going to say is in the past 2 seasons, you've specifically said, don't use it. Here, you are kind of in a more kind of positive approach, which is you're saying it's recommended as an option. What if you just said LAIV is an option for influenza? Remove the statement about not using it, because I think that by using the term recommended gives it a little more kind of strength and may help to balance the messaging. Because again, we're going to have to try to message to people why again, it's always been an option, but why are we recommending it as an option versus just acknowledging it as an option, putting in the caveats and let people make that decision.
So that would be an amendment if any of the members of the committee would care to make an amendment.
I would. I like that idea. I think you're making a very good point, and using the term recommended there can be a source of confusion. If instead it said something like immunization providers may choose to use any licensed influenza vaccine, age-appropriate licensed influenza vaccine, including LAIV, that accomplishes the same thing without making a recommendation.
Okay, so could I have an amendment to change the wording? And then we'll vote on the amendment, and then we'll vote on the whole thing.
Let's call that an amendment.
You need to tell us what the wording is.
Now,
The wording has to be clear.
Before he starts wordsmithing, can somebody type up there, please?
Yeah, we need to have clarity on what the language of the amendment would be.
Yeah, just give us a second.
May I ask a question while that's occurring? Is there a necessity in the language that the word recommended be used?
So no, this is an ACIP recommendation, but the recommendation does not have to include the word recommended.
Thank you.
But thank you for that clarification. Dr. Bernstein.
irrespective of how the vote goes here and whatever wordsmithing we choose, how will we evaluate the use of this vaccine next season? What measures of success or how will we evaluate that it was the right decision?
Dr. Belongia.
Yeah, thank you. That's a great question. So if the vaccine is allowed to be used, presumably there'll be some use of it next season, probably not as much as during a normal season because of the issues that have been discussed in the timing. However, the U.S. Flu VE network enrolls thousands of kids, or well, thousands of people and many children every winter. So if there is enough uptake, and in a normal season before this decision was made almost 2 years ago, there were enough, obviously, enrollments to get a good estimate of LAIV effectiveness. And so we would be able to do that again, if not next year, if uptake continues to increase, presumably the year after that. Of course, it all depends on whether or not there's enough H1N1 circulating. If there isn't, then we're not going to learn anything about H1N1.
Thank you. I saw a hand back there. Is Dr. Nikoski?
Hi, Martin Natoski, America's Health Insurance Plans. I'm confused about the recommendation without the word recommended in terms of payment and coverage under ACA. Is any recommendation, regardless of whether or not the word is used or not, recommended?
So I think,
go ahead.
I think that the
That's how I'm
language
interpreting
that
it.
it is an option and it will be included on the schedule is
Anything included on the vaccine schedule is covered under the ACA regulations.
Right,
If this is helpful, we have a statement, I don't know if this helps or not, but we have a statement early on in the recs for the last several seasons that says a licensed age-appropriate vaccine should be used. That's what's recommended.
Jessica, are you ready?
Dr. Stevens, in the meantime.
So I want to go back to Dr. Lee's comment about preferential recommendation. Is that a recommend? Are you putting that as a motion?
No, I asked her to hold on that. I think that really would constitute a separate motion. That's not an amendment.
That's what I'm asking. Is she making a separate motion?
Not right now.
Not right now. Okay.
We're only on the first motion, and now we have a amendment to the first motion. So, this is, so it's this, So wait, I'm not clear what you're proposing as the amendment.
The second instead of the first.
He suggested the language that's at the top, and then I believe, Dr. Belangio, your language was closer.
No, the top
oh, no.
is the
Oh,
original
sorry.
language.
Take out recommended.
Right.
Just take out
Can
the
you
word
take out recommended and just say LAIV4 is an option?
Yes.
I'm not sure which way this conversation is going, and I feel like at the moment there are so many alternatives going around that it's hard to know what we're debating. However, we as CDC with our implementation partners have to take the guidance you make and figure out how to communicate it. I am struggling to know how I would communicate that, as opposed to the second recommendation, which is what Ed Belongia recommended. So I don't think we meant you to take out your recommendation. I guess I would just say that if you are voting for this first one, it would be helpful to me to hear a little bit more about what the intention of that was. Now, if you're voting for the second one, I understand what I would do about that.
So I think what we were suggesting is to leave the second part, but just to change the wording in the first part. And I think Amanda's getting that done right now. Yes, Dr. Moore.
I'm trying to recall the exact way we used to have the wording, and I think that's what Dr. Belongia was getting at before we made the change with LAIV. We made some simple statement about any licensed, may choose to administer any licensed influenza vaccine was the way it used to be worded. It was just choose one and that's age appropriate or that's
right,
licensed.
so I thought you guys were recommending not saying the first bullet and just saying the second bullet. Did I misunderstand?
I think there were a couple of different recommendations. I think not saying the first bullet is a little bit confusing to people. I think we need the first bullet. in addition to the second, and I think the second bullet is great.
Could the second one include any licensed influenza vaccine, including IIV or LAIV?
Or RIV?
RIV.
So that's what it said last year.
So, Dr. Szilagyi.
Yeah, I want to make that point because if we only say the second point, we don't even mention LAIV, and many providers just assume it was not licensed anymore. So I think we need to tie the second one to the first.
I only wanted to mention this in case it got missed. The current language, and this is what it changed to after getting to your point about what changed from before the recommendation went away to after it did, was we used to say any licensed age appropriate. Now we say any licensed recommended age appropriate. So I don't know if that impacts this conversation, but I thought I should mention it.
So it should say any license, quote, comma, age appropriate. Is that what you're saying in the second bullet?
Any license, comma, age appropriate, influenza vaccine, comma, including IIV, LAIV, and RIV. I'm just, yeah.
Okay, give us
So
a
when we
moment.
get this language back up, just to sort of go over process, we will need to vote on the amendment prior to voting on the proposal. We will take public comment after, if the amendment is approved, we will decide which one we're voting on by approving or not approving the amendment, and then we'll take public comment prior to the vote.
Okay, can we take a vote on the amendment? This is the current wording as amended. Together. No, together.
I think it optimally works best if you take the top sentence and you put it after the bottom one, but you don't repeat for the 2018-19 season because you've already said that. So
I promise we will wordsmith.
Okay.
The intent of this
The intent
amendment.
of this, okay. Are we clear enough about what we're voting on with respect to the amendment? Okay, then I'd like to call the question for the amendment.
So we're voting for the amendment. Please check channel 71 and then point.
Can we just clarify, you can vote for the amendment
and
then
vote no.
Vote no.
For the vote.
For the vote.
Yes. So the only thing you're voting on is whether or not we can amend the original proposed language to this. You are not voting for or against this recommendation at this
Right,
time.
and if you vote against this wording, we go back to the original wording. Do it.
So that's okay. We don't have a slide for the amendment electronically. I think, can we go around the table, please? Because I think it's okay to go for the amendment.
All right,
Okay,
so let's start with Dr. Moore, since she was.
Sure. More yes for the amendment.
Dr. Bernstein?
And we're using that other whether to, we're not
Just voting on whether you wanted the language to be changed or not.
Before the vote.
Sure. Yes.
Thank you.
Walter, yes.
Riley, yes.
Stevens, yes.
Bennett, yes.
Romero, yes.
Szilagyi, yes.
Pellegrini, yes.
Hunter, yes.
Atmar, yes.
Lee, yes.
Belongia, yes.
All right, I think we are good. We have adopted the amendment, and here, is this the final wording?
So this is language for the vote, and if everyone is ready, we will take public comment prior to the vote. And we have 2 people registered for public comment. We have Ms. Andrea Woodruff and Mr. Del Bigtree.
Del Bigtree. I'm here for the Informed Consent Action Network. I was previously a producer on the daytime talk show The Doctors for 6 years, where I won an Emmy Award. And I think what's being missed in this discussion is public perception. It's a very difficult discussion you're having, and watching it's very informative, and no one would want to be having to make the choice you're making. But what I want to point out is that removing flu mist was a big story in this country. And unlike other choices you make, the public is very aware that it was taken away. So when you put it back, the media is going to be very interested in why. And when you have to discuss why, as the CDC, your response looks very flimsy to me that, well, they've changed the H1N1, and though there's no proof of its effectiveness, we're going to go ahead and recommend it. We're talking about at a time where the question of influenza vaccines effectiveness, period, is in massive question in this country. Everyone's hoping to see a better vaccine, a more effective vaccine, maybe a universal vaccine. And when we find out ACIP is just approving an old vaccine that may still be ineffective, maybe even worse than ineffective, or what is currently being used, I really question whether you're going to do serious damage to the perception of ACIP and what you're doing here, and the CDC and what it decides to approve or not approve. The country is looking for a better vaccine, not one that may possibly be less effective than one we're using now. Thank you very much.
Thank you.
Ms. Woodruff?
I heard a great question earlier with the H1N1 strain of the vaccinated versus unvaccinated. It'd be nice if you could routinely publish all strains, if it's vaccinated or unvaccinated, especially with pediatric deaths. And I'd like to know why they are choosing not to be vaccinated. Is it because they don't think it's effective, or do they have an egg allergy? Did they have an adverse reaction? That kind of information can help me as a parent make better decisions. Thanks.
Thank you.
Thank you. Before we vote, I apologize. We do have one letter that we just received yesterday that is not on y'all's files yet. I apologize. It's from the Alachua County Board of County Commissioners. They submitted a letter during the last ACIP meeting as well, and I will hand it out to you, but it is supports availability of LAIV for school-based clinics.
Any further comments? Ms. Stinchfield?
Yes, Patsy Stinchfield, NAP. So at Children's Minnesota, where I work, we have 12 ambulatory clinics, about 50,000 primary care patients. And our clinicians will like this as much as they like our optional vaccine recommendations that we make. It's going to be difficult. Two things I would like to ask. Some of our clinics will have 80% VFC kids, and some are half and half, some are the opposite. We are committed to the same standard of care for our children regardless of their ability to pay or not pay. And so for us to practically apply, when I heard that this LAIV would not be part of VFC, that is a bit of a game changer. And so two things. I'd like to ask if we could have a group take a look at some of the financing and potential VFC finance aspects afterwards. Can we shift, if we use private pay, can we shift and borrow from private to cover VFC kids? I just can't imagine saying, well, what is your insurance? Oh, I'm sorry, you have to get a poke today. So I think we really need to take a look at that and how we're gonna have disparities that are really gonna be a problem in the field. Secondly, I just think many people here today have talked about the messaging and vaccine efficacy messaging. We've been quoting Australian numbers all year long. We just had our own US numbers. Everyone's quite confused about this. I'd like to see more committee members working with CDC Communications Department on what really are our messages about influenza. Thanks.
Thank you for those recommendations. I think we should just clarify about VFC.
Yeah, so I just want to clarify that it's a short-term issue for this year. If ACIP makes this recommendation, then a year from now, we would be at a place where we would have VFC contracts for LAIV. But for this upcoming season, again, because the contracts are already, the procurement process is already complete, we would have a short-term potential for there being a choice.
Thank you. Dr. O'Leary, did you have an additional comment?
Yeah, just I don't want to downplay the issue of just one season for VFC. That's a really big deal for pediatricians across the country in terms of having to decide, which insurance you have and which vaccine you can get. And then, just to reiterate, within the Peds ID Society, it wasn't clear. This is a difficult decision you all have, but I think this public perception issue is a big problem. Because if we're wrong and effectiveness is not, if it's similar to prior seasons where there was essentially no effectiveness and it's a bad H1N1 year, that's a potential disaster.
Thank you. Dr. Moore?
I just wanted to follow up on the VFC question. Again, because this is just an option as an influenza vaccine, there's no, brand choice is not necessarily up to the clinicians who receive VFC products, so we wouldn't consider this any kind of disparity because they have other brands available. It is always the case in the VFC program that you must choose the inventory that's been provided from the VFC program. Borrowing is not permitted between private and VFC stocks. Except under extreme circumstances where that can be assured to be reconciled, which this wouldn't really apply to. As I said earlier, other states sometimes just send whatever product is available first, and clinicians use that, but the VFC programs in states would adapt to whatever CDC contracts are available, and we would address that with our providers. But since you've always had to keep your VFC inventory separate from your private inventory, this wouldn't be considered any different than any other year.
I think we need to wrap it up, but if it's critical, one more comment.
You don't need the second sentence because it's listed above and it actually kind of brings more attention.
I think we just voted on this wording, so I don't think we're going to revisit it, but thank you.
But just to clarify, we can wordsmith some of this afterwards as long as it doesn't change the intent of the recommendation.
Okay, I'd like to call the question because I'm starving and I don't know about anyone else. But seriously, I think this has been a really terrific discussion, and this is not an easy decision. So I'm going to pick on Dr. Szilagyi to go first.
So are we, we're going to do electronic voting. Oh, we are? Yeah, we're going to go, yes, that was just for the amendment. No, that's because we didn't prepare for the amendment.
Okay, I take it back.
So can you clarify on what you're voting again? I'm sorry, but a lot of process here.
Yes, the wording that was, can you put the wording back up, please?
This is not a vote to keep the wording. This is a vote yes or no about this wording.
That's correct.
Yes, so
Yes,
this is
the amendment is done. We are now voting on whether or not to reintroduce LAIV as an option. And this is the wording.
And to
currently.
clarify afterwards, after this vote, we can discuss how we can incorporate potential discussion of a second option after we complete this vote.
Before you start voting, can we just make sure everybody at the table understands what they're voting for? Yes.
This is the wording.
Okay, so voting is open. Make sure you're on channel 71. It's not? Okay. Now it's open, sorry.
Just to clarify, I
Yours is
think you
doing
have
something
to hit the channel button first.
Channel
71.
1.
Oh, great.
How many people do we have? Those? You too? What? Get Nana? I cannot believe that. We're not done. I apologize, everybody, for the So we're all good. Everybody has voted, so we will, everybody's in? We will show the results of this now.
Okay, so I think we should go around the table just to confirm everyone's votes, but also if anyone would like to make some comments on their vote. And we can start with Dr. Romero.
I voted yes.
I voted yes.
Pellegrini was yes.
Hunter, yes.
Fry, yes.
Atmar, yes.
Lee, yes.
Belongia, yes.
Moore, yes.
Bernstein, no. Should I explain? Or? Well, I'm worried that using a baseball metaphor, that we've had 2 strikes and the 18-19 season would be a 3rd strike.
Walter, yes.
Riley, yes.
Stevens, no. Same reasons. I'm really concerned about what this message sends.
And Bennett, yes. Now,
So we do have
Dr.
to-
Lee, did you want to make?
Well, we have to do a VFC vote.
Oh, the VFC vote first, you're right. Okay. Let's do the VFC vote, and then we'll
Would you prefer to
come
do a
back.
VFC vote after? Okay. I think she said
After?
if there
Okay,
were-
after. So Dr. Lee, if you want to make another amendment, another motion, I apologize.
So I move to recommend that we preferentially recommend IIV over IIV or RIV, age-appropriate vaccine over LAIV.
Is there a second?
Second.
Dr. Stevens seconded. Can we have discussion? Dr. Newsel?
Yes, I just want to urge the members to be very cautious. We recall the H3N2 data that we saw today. If there's really no reason to make a preferential recommendation, I think it confuses the public if we change recommendations too frequently.
Dr. Belongia?
I would echo that sentiment. I think that, for example, with the zoster vaccine, they made a preferential recommendation. There was very, very strong evidence from clinical trials of superiority of that vaccine. We're not in that situation now. We hope that the new A Slovenia strain has fixed the root cause of this. We don't know that for sure, but the uncertainty, in my view, does not justify a preferential recommendation, given that we do see variation from season to season, from product to product. We don't normally do product-to-product comparisons. And I think if we did that, it would essentially be interpreted as really no change functionally. So I would not be in favor of that.
Dr. Walter?
Yes, I think for the same reasons, given the season-to-season variability and unpredictability of flu and flu vaccines, I would not opt for a preference.
Dr.
I was going to
Szilagyi?
make exactly the same point, that a preference to me requires very clear data about the actual vaccine, and we have uncertainty here, but I don't think we have enough data for a preference.
Ms. Pellegrini?
Okay, this one now I am struggling with, because I think from a messaging point of view, this would actually make a lot of sense, that we are sort of cautiously wading back in with LAIV. We aren't ready to give it necessarily our full-throated endorsement, but we're willing to let it become an option so that we can collect data, so that we can see what it does, hopefully over the next couple of years, even though we may or may not have an H1N1 season. So this is tough.
Other discussion? Dr. Hunter?
I didn't want to bring this up, but let me get my notes out, just 1 second. It might make more sense to state this as LIV is not routinely recommended but should be available for individual clinical decision-making.
So we've already done the vote on the recommendation. We're looking at a different motion right now, which is to make a preferential recommendation for IIV over LAIV.
Right, I understand that. That's why I didn't want to bring it up.
I misunderstood you. Dr. Fry.
I have to say that I sort of fell off the fence the other way. When I first heard your recommendation, I liked it. It gave me more wiggle room, if you will, made me feel better. But I guess what I would say is if I didn't want people to use LAIV, I think we should have voted against it. And so I don't think we need to make that amendment, I guess is what I'm saying.
Thank you. Dr. Riley?
So I feel like I'm waffling in my own mind, but part of the reason I voted yes in the first place is because I was thinking in terms of LAIV versus nothing. So I feel like give people as many options to be vaccinated because being vaccinated is better than not being vaccinated. I feel like to now take the next step and have a preference over which one of those vaccines is taking a step for which I'm not sure the data is all that compelling, and so I worry about that.
Thank you. Dr. Brady?
I was just wondering, while it doesn't say the word